Okay, so welcome. We're obviously very, very pleased to see you all here for this session, myeloma session, getting clear answers, we hope, to complex treatment challenges and multiple myeloma case discussions. So very, very pleased that you can all be here today. So I'm Brian Dury, and you can see my affiliation there in Los Angeles and my disclosures, and I'm very pleased to be able to lead this illustrious panel that has been doing a good job for several years now. So immediately to my right is Bruno Paiva from Navarra in Spain, and obviously he is very much involved in the flow cytometry core at the university there, and you see his disclosures. To his right, we have Vincent Rajkumar from the Mayo Clinic, whom you all know very well, I think. And Philippe Moreau from Nantes in France. Very, very pleased to have Philippe back with us again this year. And of course, last but not least, Jesus San Miguel, also from Navarra in Spain, and very, very pleased to have him as a faculty member. So, what is the format this year? Well, it's very, very similar to the last couple of years. So each topic will be discussed, and so there will be a case presentation, and then there will be an audience response. And so if you look at the back of the chair in front of you, except for the front row, you'll see that there is a handheld dangling there in front of you, and these are very simple. They have numbers. They also have a ABC. Our questions and answers are in number form, and so just press the number, and you can change your answer. The last number that you present will be your answer. After you do that, there will be a presentation by each of the faculty discussing the topic in question. After that, there will be a discussion with the panel, and then you will see what did the panel recommend for each of these questions, and then we will have some audience discussion, and then you will vote again. So after all of that's happened, we'll have you vote again to see if we influenced you in any way with your choices, and we will do this throughout each session. And so we are expecting and really hoping that most of the discussion will occur in sync with each segment as we go forward. And at the very end, we will do something which was, I think, quite popular last year, which was to give our takeaway algorithms of what are the recommendations from frontline all the way through to later relapse. Okay, so first of all, to kind of test out the handhelds, let's have a polling question, and it's relatively simple, although it's interesting to see what is the experience in terms of myeloma numbers that you take care of in a typical year. So if you don't mind going ahead to answer this first question. I thought we were going to have music. No music. There we go. All right, so we have quite a range. 18% over 100, about a quarter, fairly small number, but very, very interesting, a range of experience. So, the different sessions, which I'm sure you've seen on the agenda. First of all, accurate diagnosis and when to start systemic therapy, induction therapy, the role of transplant consolidation and maintenance, and in this area, an emphasis on what is the current role of MRD testing. And then the last two segments are related to relapse therapy Jesus will cover earlier relapse, and I will cover later relapse options. So without further ado, I'd like us to get started, and I would like to invite Bruno Paiva from the University of Navarra in Pamplona to present how do we accurately diagnose myeloma and when should systemic myeloma therapy be initiated. So please welcome Dr. Paiva.
Well, thank you, Brian, and thank you for the invitation to be here this afternoon. This is a 50-year-old asymptomatic male with elevated total serum proteins, yet a normal albumin during a routine analysis. Further laboratory testing showed normal hemoglobin, creatinine, and calcium levels together with a normal liver function. An IgG kappa M protein was detected in the serum, 3.5 grams per deciliter, with hypogammaglobulinemia. The serum free light chain ratio was 85. Skeletal survey, PET-CT, and MRI showed no lytic lesions, increased uptake, or the presence of focal lesions. The microscope showed 12% of plasma cells in the bone marrow, out of which 97% were abnormal by flow cytometry. FISH was performed on CD138 positive isolated plasma cells, and 17p deletion was counted in 30% of the nuclei. So let's vote. In your current clinical practice, would you consider this patient a candidate for treatment? And the options are yes, because the patient has active myeloma, yes, because the patient has high-risk smoldering myeloma, only on a clinical trial because the patient has high-risk smoldering myeloma, no, because the patient is not at high risk for progression, or unsure. Please vote. Okay, we have a winner, which is option number 3, only on a clinical trial because the patient has high-risk smoldering myeloma. Number 2 is treating the patient, I would say eventually outside of the clinical trial. Well, after 1 year, the patient M protein increased by 15%. The free light chain ratio is now 100th. The hemoglobin levels decreased by 1 gram per deciliter, and there are now 20% of plasma cells in the bone marrow, and according to flow cytometry, there are no longer normal plasma cells. All are clonal. So, could you please vote again? In your current clinical practice, what would you consider? Would you consider this patient a candidate for treatment after 1 year and according with those features? So now we have a different winner. Option number 1, yes, because the patient has active myeloma. And again, the second most voted option is yes, because the patient has high-risk smoldering myeloma. Number 3, only in clinical trials, again, because of a high-risk smoldering myeloma diagnosis. Well, I should start by saying that to some extent it's normal to have lack of 100% concordance. Because at the end of the day, we are trying to categorize the disease into different stages when truly the disease is a continuum from MGUS to smoldering and then to active myeloma, in which tumor cell biology and the crosstalk between tumor and microenvironment cells both play a very important role in this continuum. However, a take-home message is that in this continuum, risk of progression is different in MGUS as compared to smoldering myeloma. The risk of progression in MGUS is 1% per year, and the risk is linear. In smoldering myeloma, the risk is much higher during the first 5 years, and then progressively it becomes linear and eventually similar to that of MGUS. Which means that in your smoldering myeloma population, there are about 60% of patients in which the risk of progression to active disease is 5% per year, and these are classified as standard risk, and then 40% of patients in which risk of transformation is significantly higher. Out of this 40%, there is a specific subset of patients that have been defined by the presence of 60% or more of bone marrow plasma cells, a free light chain ratio of 100 or more, the presence of 2 or more focal lesions by MRI, in which the risk of transformation is particularly high, 40% per year. Since the risk here is particularly high, 40% per year, eventually 80% at 2 years, this was the reason why in 2014, in the IMWG updated criteria for the diagnosis of myeloma, these patients were no longer considered as having ultra-high risk smoldering, and now they are considered as having active myeloma, and in which treatment should be initiated. Why these 3 myeloma defining events, or in other words, why these 3 biomarkers and not other biomarkers to be established as a myeloma defining event? Well, the answer is twofold: positive predictive value and the fact that they are reproducible. Here you can see patients with smoldering myeloma having 60% or more of plasma cells in the bone marrow and the median time to progression of only 7 months, and this biomarker has been validated in 3 independent series. Here you can see smoldering patients with a free light chain ratio of 100 or more, a median time to progression of only 13 months, and again, this biomarker has been validated in 3 independent series. And in this slide, you can see smoldering myeloma patients with 2 or more focal lesions by MRI, again, a median time to progression of 13 months, and this biomarker being validated in 2 independent series. In my opinion, the updated diagnostic criteria in 2014 has been a great accomplishment. However, great accomplishments usually come along with great challenges ahead. I think that one of the challenges ahead is recharacterizing what is high-risk smoldering myeloma, now that all patients with ultra-high-risk smoldering myeloma are not there because these patients are now considered having active disease. This means that all the different models that have been developed in the past to identify patients with high-risk smoldering myeloma, that is 50% risk at 2 years, need to be revalidated. In fact, I would urge now the IMWG to really provide the guidelines on which should be the biomarkers used to identify this patient population. Fortunately, we have many biomarkers that, to some extent, can be categorized into 3 areas: protein production, tumor cell biology, and disease dissemination. The fact that these different biomarkers identify different patients at risk is not a disadvantage, it's an advantage. You really want biomarkers you don't want different biomarkers identifying the same patients at risk. You want different biomarkers that can identify all patients at risk. These biomarkers provide different information regarding myeloma biology, and therefore they should provide you complementary information to try and predict patients' outcome. The other challenge ahead is standardization automation. With the exception of the biomarkers that measure protein production, normal and monoclonal proteins, all the other biomarkers, particularly related to tumor cells or disease dissemination, they still lack standardization and they definitely lack automation. Last but not least, to improve the prediction of risk. And I believe this can be accomplished by combining baseline risk stratification with further recalibration of risk every 6 or every 12 months. Certainly, if you would like to repeat the biomarker frequently, this means that the biomarker should be as minimally invasive as possible. I truly believe that all these challenges ahead are worthwhile. If we look into clinical data, and this is a recent updated analysis with long-term follow-up, median of 75 months of the KIREDEX clinical trial, LENDEX versus observation in patients with high-risk smoldering myeloma, there continues to be a great clinical benefit in terms of both progression-free and overall survival for patients that received early treatment. This is another update analysis from a clinical trial conducted in the NIH in which high-risk smoldering myeloma patients received 8 cycles of KRT and 2 years of LEN maintenance. This is a single-arm study, however, and with a median follow-up of now 43 months, I would say that both PFS and OS look very promising. There are multiple clinical trials being conducted, most of which will be presented at this ASH meeting. To some extent, this can be divided into those clinical trials with a more soft approach based on a single agent and other clinical trials with a more intensive approach based on combination therapy. As I mentioned, this will be presented at ASH, and therefore I'll not go into any detail. I would just like to highlight 2 points. Number 1, inclusion criteria, which is different across studies, and this will pose a challenge if we want to make an overall interpretation of the data that is being generated, and also CR rates and outcome. As expected, the most intensive approaches are producing the higher rates of CR. However, at least the progression-free survival at 1 year is comparable across many of these studies. This means that eventually, for the years to come, there will be some debate about what would be the best approach for high-risk smoldering myeloma, either disease control eventually to a single agent monotherapy, or a more intensive approach with the aim of curing the disease by preventing its malignant transformation. I know that the ASCENT clinical trial will start at the beginning of the next year in the US. The CESAR trial has been conducted in Spain, and Mariví Mateus will present for the first time data about his clinical trial this Sunday morning. In summary, I believe that better understanding of myeloma biology as well as the development of sensitive biomarkers have contributed to accurately diagnosing myeloma, and now treatment should be initiated in the presence of CRAB and or one of those 3 myeloma-defining events we have seen early on. In my opinion, there are 2 goals by initiating treatment earlier. One is the prevention of organ damage, and I believe this has been the greatest accomplishment of the 2014 updated diagnostic criteria. The other goal would be to cure the disease, particularly those subsets in which it remains largely incurable, for example, revised ISS3, by treating earlier, intensively, or with disease control and preventing the malignant transformation. Whether disease control versus disease eradication, which option would be pursued, this is something that should only be addressed in the setting of clinical trials. And this is why I also urge the IMWG to work further and develop guidelines to standardize biomarkers, either invasive or minimally invasive, for uniform identification of patients with high-risk smoldering myeloma to be enrolled in those clinical trials. This is my last slide. I'll stop here. Thank you for your attention.
So thank you very much, Bruno, for this excellent summary of the current state of the art in terms of the diagnostic criteria and then the ideas about intervention. And so what we're going to do first is just to remind you about the case, which you voted on already. And so the first question is, what did the panel think about this case? And you can see in this instance, all of us felt that the patient has indeed high-risk smoldering myeloma, and that we at least would only consider treatment of such a patient in a clinical trial. And so I guess possibly a first point for the panel would be, I noticed that around a third of the people in the room said that they would treat the patient, but not within a clinical trial. And so I don't know who might wish to comment on that first. We obviously feel fairly strongly that right now, although we have the data on Lendex, and we have these other trial data, that we would still focus on clinical trials.
Yeah,
Jesus?
I would support the conclusion of treating only in clinical trials, particularly because in the CureDex trial, we included, at that time was not available the information on the ultra-high risk. We included high risk and ultra-high risk. Now in the CESAR, we have separated these two populations, and we are going to have this information. But until this information is available, my recommendation will be just to restrict to clinical trials and to do a close follow-up of these patients.
Right. So the second point here was, we'll just do this first. So the second point was, with the changes in the findings, the M component increased by 15%, and then the serum free light ratio increased up to 100, which is actually the cutoff criterion for the new diagnostic criteria for myeloma. What did the panel think? Well, the panel felt that the patient now has active myeloma and should be treated with myeloma. And so this is a central point of the new criteria, is to focus on these new myeloma defining events as a basis to say that a patient does have active myeloma and to proceed with therapy. So maybe Vincent, I mean, you were the one who is the lead author on the diagnostic criteria. Can you maybe comment on any issues that have emerged in implementing these new criteria, using the free light ratio, the MRI with 2 or more lesions? What comments would you make about that?
Thanks, Brian. Since we published the criteria, we've, of course, had a lot of feedback and a lot of information has come through. My first point would be that prior to the new criteria, we needed to exercise judgment in evaluation of bone disease, in anemia and renal failure, just making sure that it was indeed really related to the plasma cell disorder. That judgment call still needs to be made now. You still have to do the same thing with the CRAB features, and you also have to do the same thing with the other ones. I mean, MRI focal lesions could be tiny, could be something that you're not sure of, then just wait. Repeat the MRI in 3 months, 6 months. It's not an emergency.
So that actually is part of the criteria, is a specific recommendation if you're unsure to wait and repeat in 3 months.
Exactly. Same thing with the free light chain ratio. If the free light chain ratio is very high, 90% of the time or more, the patient does have a very high risk of progression because they also have a significant urine M spike. But there are occasional patients where the free light chain ratio is high, not because of a high tumor burden, but because they are dimerizing, and the levels are high in the serum, but hardly anything is there in the urine. And those patients you can probably watch. Similarly, there are patients where you've known that they've had a light chain very high for many, many years. That's not the patient we're talking about either. This is a brand new patient where you don't know. So I think the point number one is just exercise judgment.
Right,
and I think the second point is that you can see that in this particular patient's case, there's another phenomenon that happened. It's not just that the patient had a free light chain ratio of 100. The patient also had a rise in the monoclonal protein accompanied by a drop in the hemoglobin. We have published that those kind of patients, particularly if they have 20% plasma cells, are at more than 90% risk of progression within 2 years. So that's another reason to keep in mind.
So Jesus or Philippe or Bruno, I mean, any additional comments?
No, I think I would like to emphasize what Vincent has already mentioned. In the past, we were really used to judge on anemia. Is this anemia due to multiple myeloma or there are other causes? Even lytic lesions could be metastatic lytic lesions. In the paper, in the Lancet paper with the new criteria, it's specified that if you are in doubt, you don't treat, you repeat the evaluation, then again, the clinical judgment should be superior to any biomarker.
Philippe?
So, yes, if I may add something, Brian, regarding the clinical trials for smoldering myeloma. We will have during the meeting very important information from Spain, for example, with a very aggressive treatment, the CESAR study, with a very intensive treatment, stem cell transplantation, aimed at curing maybe some patients. And I think that we have here a gray zone. Even within experts, we are not totally in phase about the optimal clinical trial to be proposed to these patients. On the opposite, we have some clinical trials ongoing only with daratumumab, single agent. Are we going to cure a patient with smoldering with dara alone? That we don't know. We also have another study with Lendex elotuzumab, for example. So we have huge differences in the clinical trials that are currently proposed to those patients with a high-risk smoldering myeloma. Even a single agent that is active but maybe not aimed at curing patients, and the opposite, the atomic bomb from Spain, aimed at curing some patients. So clinical trials are important, but we can see here that we are not really sure about what is the optimal clinical trial for those patients.
Right, so maybe we can ask the panel to give their preference. We have these two choices. We have the CESAR type trial with an aim to try to achieve cure, or the monotherapy with DARA, or a control approach. And so maybe each of you can answer, if you have a patient, which one would you offer?
Well, I can start. I think that the fact that we still don't know what is the best approach just really emphasizes the fact that the treatment of these patients, and again, we are mentioning high-risk smoldering myeloma, should only be performed in the setting of a clinical trial. I think that given the fact that even with the best or the optimal treatment approaches in newly diagnosed active myeloma, at least for some subsets, they are clearly not yet capable of translating into a cure. To try and pursue the cure for those patients early on, if this is possible, this is something that is very attractive.
Right. Vincent, will you accrue to the ASCENT trial or to the DARA trial?
Well, I think I don't have smoldering myeloma. I think that is the main thing to keep in mind. We don't have smoldering myeloma. We have to ask the patient what would they like, since we don't know.
All right.
Some patients may want the kitchen sink and may want the curative approach. Some patients may be worried and they would like a benign approach that would delay progression by a few years, and then they can make the decision. So since we don't know which strategy is actually going to come out superior, the curative strategy may look nice right now, and then later on we find there's too many toxic deaths. The control strategy may look very nice right now, and maybe later we find out we didn't do much. So since we don't know where the outcome is going to be, we better leave the choice to the patient. Oftentimes, we don't have that luxury because we don't have both kinds of trials available at our institutions, so we just go with what we have. I myself, I'm involved in the leadership of trials investigating both strategies, from single-agent lenalidomide, single-agent daratumumab, to Lendex versus Dara-Lendex, to the ASCENT trial, because I'm keeping an open mind.
All right, so quickly, because we have to go back to get some feedback from the audience. Any more comments? Maybe you have the CESAR trial, obviously, and Philippe, I don't know.
Yeah, our first approach was to try to control the disease, to delay the progression. And this is why we designed it really something convenient for the patient, oral. And we found that it was associated with an overall survival benefit, what was not expected and was not an endpoint, a primary endpoint for the study. Then having this data, we say, okay, and we know that the mutational load increase with the progression of the disease is higher in active myeloma than in smoldering myeloma. Say, okay, why not to try to have a different endpoint, and this is MRD negativity at 5 years. In other words, to try to cure. I think this needs to be investigated if early treatment changed the outcome. And this is something that, for all the audience, I think is important, both either the control or to try to cure.
Okay, so let's get back to the audience. So first of all, any immediate questions or comments from the audience? Then what we're going to do is have you vote again to see if we've changed any opinions about these aspects of the case. Any? Yes? Yeah, go ahead.
I have a mic.
Treating high risk.
Yeah. So if you don't have a study available, what are you going to do?
This is a very difficult question. I mean, it is very difficult, and I have discussed this in the blood paper with Dr. Mateos and Ola Landgren. And I will show it in the algorithms at the very end of the thing. I mean, it really depends on the patient, whether they have one high-risk factor or multiple high-risk factors.
I think this is very important.
Right.
Yes, and I would rely on the Spanish trial if a patient with high-risk smoldering myeloma has multiple risk factors. And if they are interested, I am comfortable offering them not the Caesar-type trial, but treatment like myeloma. I mean, that's controversial, but we'll discuss that in the setting of the algorithms.
All right. So let's go ahead and have you vote again. So you've heard the case now, and you've heard our discussion points, and let's vote. So the first question was, what would you do for the patient? 1, 2, 3, 4, 5. If you wouldn't mind voting one more time. Oh my goodness. Whoa. All right. So we have a little bit of a shift. So we went from 55% to 62%. So that's kind of interesting. Okay. That's very odd, actually. What can I say? All right, so I don't know how much impact we're having up here. Maybe we need to be a little bit livelier and maybe make our points more strongly. I think, Vincent, with this in mind, I invite you to come up and talk about individualized treatment for induction therapy. Please welcome Dr. Vincent Rajkumar.
Thank you. Thanks so much for having me again, Brian, and look forward to discussing 4 cases with you. The same patient, but slightly modified. Let's go with the first one. The patient is straightforward standard risk myeloma. 62-year-old, referred to find out what's the best treatment for multiple myeloma. Baseline data shows anemia, serum monoclonal protein 2.5 grams, IgA. Urine monoclonal protein shows a fairly big M spike of 1,100 milligrams for 24 hours. Serum kappa free light chain is 800, lambda is 10, and free light chain ratio of 80. Low-dose CT scan shows multiple bone lesions, bone marrow biopsy 45%. Patient has multiple trisomies on FISH, no high-risk translocations, no high-risk abnormalities. So straightforward, standard risk, multiple myeloma. So the question is, what would be your initial therapy for this patient? Bortezomib Lendex, VRD, bortezomib melphalan-prednisone, VMP, carfilzomib Lendex, cyclophosphamide, bortezomib dex, that's the CyBorD regimen, Activism Blendex, or just Lendex? So great, 60% picked VRD or bortezomib Lendex, and then there are some who have picked carfilzomib Lendex or Cyborg-D. Very few have picked melphalan-based regimen. Let's say the same patient, keep in mind, but we'll change the age of this patient to more than 75, not 62 anymore, more than 75 standard risk patient. What would you choose? And the same options. Go ahead and vote. Okay. Now we have a nice dispersion of the various options, and looks like Lendex doublet is winning. Brian, let's see how much I change this. The next patient, I'm keeping the patient the same, young patient, and then I'm changing the cytogenetics. Now we'll make the patient have a high-risk cytogenetics, deletion 17p. Now, how would you vote? Or would this even affect your choice? Okay. Now, this is divided among people who have seen the MSmart webpage and the people who have not. So it's VRD versus KRD, 40-40. And then the final one is if the patient has a high creatinine, like say very high creatinine. What would you do? At presentation. And here the winner is cyclophosphamide, bortezomib, dex, Cyborg-D. So same way we've asked the panel to vote. When I finish my lecture, we'll go ahead and see how people voted, and then we'll discuss the answers. My job now is to see if I can walk you through these 4 patients and try and see why I would recommend certain things the way we do. First problem is that myeloma is not one disease. These are truly the multiple myelomas. There are at least 6 different cytogenetic types of multiple myeloma. There's probably about 5-10% with myeloma who don't fit any of these 6, but almost all patients can be put into one of these buckets. Trisomies 11, 14, and 6, 14 generally do well. 14, 16, 14, 20 has consistently had poor prognosis, and 4, 14, depending on the study, varies, so it's intermediate risk. Added to that, there is gain of 1q or amplification 1q and deletion 17p, which have been associated with high risk. These 2 are not defining types of myeloma, but they can occur in any of the primary 6 types. So for example, 11-14 patient can get a deletion 17p, or 4-14 patient can get a deletion 17p. So they're not disease classifying, but they modify the risk of the patient. And you can see the presence of deletion 17p immediately makes somebody high risk. It's not just disease biology that affects outcome. As you know, 2 other important factors are the fact that you have host factors, particularly in multiple myeloma, renal failure. Renal failure dramatically changes the prognosis of patients. Even if you manage to reverse the renal failure, it still can cause problems down the road. The tumor burden affects the patient. How much tumor, multiple lytic lesions, extramedullary disease, aggressive disease, so that also affects the outcome. So we also have advanced age. Advanced age affects outcome because one of the important treatment modalities we use for myeloma, which is autologous stem cell transplant, we often are not able to use in elderly patients. So it does affect outcomes. So outcome in myeloma is affected by host factors, it's affected by tumor burden, biology of tumor, and of course also response to therapy. Now, if you take the first patient, standard risk multiple myeloma, newly diagnosed, with transplant eligible patient. There are so many clinical trials that have been done. If you look at the NCCN webpage, you'll probably find 10, 20 different options that you can do for these patients. Many clinical trials have compared old treatments to new treatments or did not have a survival result. I'm asking you to remember only one clinical trial for this particular patient. This is the only trial that I know where two modern regimens were compared. Both had lenalidomide, and it looked at a doublet RD versus VRD, and it was associated with really impressive results. Number one is that VRD was superior to RD. But more importantly, if you start a patient on VRD, it is quite well tolerated, and it takes about 4 years for the first relapse to occur. And that's important to keep in mind. In 4 years, a lot can change in myeloma. And you have a very good regimen that can accomplish that. And in this study, you have an overall survival in excess of 6 years. This is a study with real-world myeloma done in the US where the median age was 65. So it really reflects, and there were no transplant involved in this study. So it tells us that VRD as a regimen, not only is it well tolerated, but gives you a PFS of 43 months and overall survival of 75 months, and it's clearly superior to Len-Dex. So VRD really has become our default frontline standard therapy. However, as we know, we are going to try and see 3 is better than 2, so we are going to have trials which are looking at are 4 drugs better than 3. And the new kid on the block is daratumumab. There are going to be studies looking at, can we improve VRD by adding daratumumab? Can we improve KRD by adding daratumumab? Can we improve any triplet regimen? And in this meeting, there is an abstract that I want you to pay attention to. It will be presented as a late-breaking abstract that compared Dara VMP versus VMP. It shows superior response rates, as you can see, and it shows superior progression-free survival. Do we change our approach to newly diagnosed myeloma and start using quadruplets based on these results? No. These are very early results, number one. There's no overall survival. Number 3 is that this is using a melphalan-based regimen, so it really probably doesn't translate to what will happen with Len-Dex-based regimens. And then finally, the trial design itself has some issues, which is that after 9 cycles, the trial is not really a 4 versus 3, but rather daratumumab versus no daratumumab. So that also is there. But it's important because this established the principle that we're going to try and include monoclonal antibodies into frontline therapy sooner or later, and that future is coming. But for right now, I think VRD is the standard of care for newly diagnosed myeloma. The second patient I mentioned was somebody who's older than 75, and here most of you pick Len-Dex. And I think that's the reflex because we think an elderly patient may not be able to tolerate bortezomib Len-Dex. And here I would like you to focus on a particular paragraph that is in the Lancet paper from Dr. Dury, which was, they did analyze this group of patients by age. And patients over the age of 75, the median progression-free survival was superior with VRD than RD. The median overall survival was superior. So even in older patients, disease control with a triplet seems to be associated with better progression-free survival and better overall survival. So my choice actually for the patient, the second patient, is also VRD. The first patient was VRD, and the second patient was also VRD because an elderly patient, provided they are not very frail and multiple comorbidities and could go on this trial, did quite well on VRD. But there are patients who didn't enter that SWOG trial because they had poor performance status or they had multiple comorbidities. So we are going to have some frail patients, and for them, I would refer you to the doublet trial that looked at the first trial of MPT versus RD. And there you can see RD given until progression is associated with a really nice progression-free survival advantage over the other regimens, and it's really well tolerated, and that would be still an option. So those of you who voted doublet, if you thought that the patient was frail, I think you're right. If the patient was elderly but in really good shape, I think you can still get away with VRD and it'll give you better outcomes. That's my second comment. Now the third patient is the patient who has acute renal failure. Now this is common in myeloma. About 15% of patients will present with a very high creatinine, often sometimes even needing dialysis. And in these patients, Lenalidomide as a frontline is really not realistic because number one, the dosing in acute renal failure, you don't want to be guessing at that time. Number two, it takes a few days, a week or so to get lenalidomide, and you need the response today. Same thing with thalidomide. So our default is cyclophosphamide, bortezomib, dex. That is what most of you picked, Cybor-D, and that's what most of us use for patients who present with acute renal failure. I have put in this slide something else that we do, which is plasma exchange. That is a very controversial thing, but plasma exchange or extracorporeal removal of the light chain with the high cutoff dialysis filter, accompanied by immediate prompt therapy with a triplet like Cybor-D, can reverse the renal function in most patients. So that's our strategy. Now, the fourth patient is a patient with high-risk multiple myeloma. Here, people were split. Some of you said VRD, which I think is probably the safe answer based on evidence alone. And some of you picked KRD. And KRD, the reason the Mayo group has KRD for young patients with high-risk myeloma is based on the following. Number one, KRD seems to be associated with a higher MRD negative rate, a higher CR rate than VRD based on non-randomized comparisons. These are prone to error. We are aware of that. And the reason why we think it's promising and something that we are worth considering is that we are willing to break the rule for high-risk patients. These patients, we know how they do in VRD trials. Their outcome is quite bad. And we don't want to keep doing the same thing where we know that the outcome is bad, and we are willing to take a gamble on carfilzomib lendex just in this particular population. I know we might be wrong, but in the young patient, we think it might be reasonable. It's associated in the Jakubowiak study with an 42% stringent CR rate. Almost all of them were MRD negative, and they're doing well on long-term follow-up. And number two is this paper from the NCI, where the overall CR rate was 56% with just KRD alone, and 2/3 of the CR patients were MRD negative. There is a trial going on comparing VRD to KRD in the United States that's still accruing. It's accrued over 750 patients. Another 250 or so will be accrued. However, that trial is mainly looking only at patients with standard risk myeloma. For high risk myeloma, the SWOG group has already decided that they would go ahead with KRD versus KRD for DARA as their next clinical trial. So this is my recommendation based on risk, is that for patients with del-17P, particularly del-17P, KRD is a reasonable frontline. Transplant eligible young patients. For elderly patients, regardless of high risk or low risk, I do not recommend carfilzomib-based regimen for right now because the Clarion study gives us pause. This was a study done in elderly patients. You can see that the overall survival was actually trending against carfilzomib, whereas VMP was living longer than carfilzomib. So this gives me pause. So elderly patients with the cardiac side effects and risks, you want to avoid it until you get full phase 3 data supporting the use of carfilzomib in frontline. So bortezomib frontline for elderly. Summarizing all this, the general algorithm for patients with newly diagnosed myeloma, if the patients are not transplant candidate, we prefer VRD. If the patients are transplant candidate, also we prefer VRD. We give 4 cycles of VRD and then proceed to transplant. For frail patients, elderly with multiple comorbidities, a doublet like lendex would be reasonable. For a young patient who's a transplant candidate who is willing to take on extra risks, KRD would be reasonable for those high-risk transplant-eligible patients, and Cybor-D for patients who have got acute renal failure. There are many, many new drugs coming. You have drugs that were recently approved, all of which are going to be tried in the front line, or many of which are on phase 3 trials. So this algorithm will keep changing. We have also got many, many new drugs, including CAR-Ts coming out, so again, things will change. More important thing is to just keep in mind some key principles, wait for overall survival improvements, and that's why the SWOG trial is so important. You want to wait for phase 3 trials, not just with surrogate endpoints, but clear survival improvement. When a new regimen is promising, just consider, is it worth the cost and the quality of life and the convenience factors? And then finally, know when to break the rules. Okay, VRD is standard, but if my patient has got acute renal failure, maybe that's not the best thing. If they've got very, very high-risk cytogenetics, maybe I'm willing to change the rules. So make your own rules, be willing to change them. And I'll close with that. We can go back to the questions. Thank you.
So, yeah. Okay, so thank you very much for that very clear discussion of what we would currently recommend. And so perhaps the first thing we can do is just to go through the case and just show you the panel votes. And so the panel indeed selected the VRD regimen as the overall choice. If we look at the impact of age, this is interesting here. Again, we have VRD. You can see that I had VRD light, Philippe Moreau VRD. Then we have the Spanish, a little bit different, and maybe we can ask Bruno to explain his choice of ixazomib, and then Jesus VMP, which we obviously know is a very active regimen. So maybe Bruno, can you explain your choice of ixazomib?
Well, if possible, in the setting if that would be available, depending on the geography, basically for convenience.
All right. And so,
Yeah.
and then Jesus.
But Bruno,
yes.
To be honest, do you have any data on ixazomib Lendex frontline? We
Yes.
don't have. In fact, we are awaiting for this very important tourmaline study comparing Lendex versus Lendex ixazomib. But are you able to use this in Spain?
That's why I started by saying according to geography and availability. But again, thinking on a full oral regimen.
Bruno lives in Spain and thinks like he's in Minnesota.
And then, obviously, for the VMP, we know that Jesus loves VMP, but maybe only for 2 or 3 more days when it will shift to Dara VMP, I think, right?
No. 2 weeks. No, I think the only 2 regimes that has been approved in Spain for the elderly patients are VMP and Lendex, and in this patient without any particular abnormality, I decided to go for VMP, but for me there are the 2 regimes. Bortezomib Lendex will be an ideal, lethal bortezomib Lendex, but it's not yet approved.
Okay.
And I am afraid for most of the audience, this is a dream.
All
Okay.
right. So then for the 17P, you can see that 2 of us went with the carfilzomib, then 2 stuck with the VRD, and in this case, Jesus went with ixazomib.
Okay.
There's something happening in Spain here.
No, yes, definitely. Again, thinking about a dream and switch gears here, the only study that has shown completely overcome, and I will show later on, in the relapse setting, the adverse prognosis of high-risk cytogenetics is ixazomib Lendex. And I'm looking forward just to see if the tourmaline confirms that result. Because if this is the case, this will be very important for 17P particularly.
Okay. And then finally, with elevated creatinine, I think that we have, among the panel, a pretty consistent approach, and as I recall, also a fairly strong tendency among the audience. And so this was pretty clear. So I don't know what further points the panel can discuss. We have a few moments, so are there any questions or any things that someone might want to raise from the audience? Yeah. I'm sorry, it's hard for me to see because of the light, so if...
Hello. Yeah.
In the middle.
Okay, go ahead, please.
In the VRD for 75 years old, in your opinion, how much of the infectious issues you have seen? Because I have seen a lot of these patients, more than 75, develop pneumonia and leading to sepsis and mortality.
Yes, well, you'll notice that I said VRD light. Obviously, from the 777 trial, I am acutely aware of the toxicities as you move up through the age. And so I think that you do need to, in my opinion, you need to preemptively adjust the dose and the schedule for an older patient. So Vincent, what you just said, what do you think?
Oh, I agree with you. I'll make a couple of points. One is that there's a really important abstract, which I am dying to go see, which looked at the use of levaquin in frontline for the first 12 weeks, and it was associated with an overall survival benefit. And so for patients with newly diagnosed myeloma starting on chemotherapy.
Yeah.
Number two is that in my publications, at least my bias is the VRD I use, I think is VRD light in general. I don't use twice weekly bortezomib unless the patient's like at imminent risk of having some major problem. I prefer once weekly sub-Q, so it's a modified VRD regimen. Don't use the dexamethasone too much. In elderly patients, use 20 per week, not 40 per week. And if the patient is, there are certain ethnic groups who even 20 is too high. So you have to be very careful with the dosing. And you might have to even adjust the lenalidomide dose. So just be careful that when we say VRD, it's adjusted, but even for the young patient, I don't use the full VRD that's published. And in my papers, I've given the dosing that we generally use.
And very aggressive monitoring with regard to the neuropathy, for sure, in a proactive way. Okay, so why don't we go ahead and, yes, we had these. Bring it back, and let's have you vote one more time to see if we changed anything from this discussion, okay? So I'm going to be watching closely for these percentages, okay? So we have this case, and would you select your therapy here? So we go ahead. Let's vote again. All right, so I guess we're doing it for the older patients. All right, so we're asking you here, what would you use as your selection for this patient over the age of 75? So over the age of 75, having listened to us, what would you select? Uh-oh. All right, so here we do have a shift toward VRD, even for someone over the age of 35, and you'll notice with a corresponding reduction in the Lendex. So you can see there's a shift there from the doublet to the triplet. So you've had some impact there, but Jesus has also had some impact, some 10% improvement in the VMP arm. Okay. What about the impact of 17p minus? Here it was split between VRD and then carfilzomib Lendex. So if you'd like to vote again, if you would select one of those or maybe one of the others. Maybe ixazomib, so popular in Spain. All right, so in this case, we have a shift where about a 10-15% shift from VRD to the Mayo M-Smart. So not too much for ixazomib, though, no. All right, well, this is very, very interesting and helpful. So with that, we'll close this discussion and move to our third topic, and very, very pleased to welcome Philippe Moreau to talk about the role of transplant, consolidation, and maintenance, which obviously has been a big, big focus in the IFM trials over the years, and so please welcome Philippe.
Thank you, Brian, for this invitation. And that's funny to see that Vincent Rajkumar is presenting the frontline treatment for young patients and is not mentioning at all stem cell transplantation. That's VRD or KRD, but not stem cell transplantation. That's quite strange to me. So, okay. So this is the patient case. In fact, he's 61 with bone pain. You can see that the M spikes 46 grams, 32% of plasma cells within the bone marrow, normal calcium, normal renal function, ISS2, diffuse bone lesions on MRI. So you're going to vote and to propose these 6 possibilities: VRD times 6, followed by Lendex until progression. Could be the SWOG approach, let's say. VCD times 6, followed by stem cell transplantation prepared by MEL200. Times 4, stem cell transplantation, single. VRD times 2, consolidation and LEN maintenance. Proposal number 4, the same regimen with VTD instead of VRD. Number 5, VCD times 4, tandem stem cell transplantation and LEN maintenance, or you're not sure at all, so please vote. Okay, so a very large majority for VRD plus VRD consolidation, stem cell transplantation, and maintenance, that's fine. We have very few tandem stem cell transplantation, only 6%. Okay, interesting. And, well, Vincent, I'm sorry, but look at the SWOG approach, and Brian, your paper was published in a very good journal, but, well, 4% only, so, okay. So thank you for this. So what are, in fact, the proposal, the guidelines in Europe when a young patient is eligible for stem cell transplantation? Yes, we are proposing a triplet induction, and you can see that several regimens are available. We are proposing currently a frontline stem cell transplantation for all patients with a single stem cell transplantation and lenalidomide maintenance that is approved, that is reimbursed in many, many countries now. So these are the current proposals in Europe. And you can see that there are some issues, in fact. We are not mentioning here in our guidelines any consolidation. So should we use? Yes, no. And the majority of you are proposing consolidation with VRD times 2, okay? There are some issues regarding single versus tandem stem cell transplantation. And very few of you are proposing a tandem, okay? We are going to discuss briefly this point. But, well, we need to improve on the results, and we need also to monitor maybe differently the quality of the response in the future. So consolidation, yes, no. Should we use a consolidation that is currently not proposed in the European guidelines? We have very different results when looking at the EMN2 study. Patients were receiving an induction with VCD VMP or VCD stem cell transplantation, and then following the induction part, they were randomized to receive VRD times 2 or no consolidation. So the study was reported last year at ASH, and in fact, the results are in favor of VRD consolidation for progression-free survival. The follow-up is too short for OS, but nevertheless, the European study on a very large number of patients is showing that maybe we should use VRD consolidation or a triplet consolidation. Exactly during the same meeting, 1 year ago, in fact, we had the results of the STAMINA study from the US. Patients were randomized following single stem cell transplantation to receive no consolidation, consolidation with VRD times 4, or a second stem cell transplantation. And in the 3 arms of the study, LEN maintenance was proposed until progression. And at the end of the day, the follow-up was rather short, but nevertheless, on an intent-to-treat basis, no difference when looking at no consolidation, VRD times 2, or a tandem stem cell transplantation. So in Europe, VRD is good, and in the US, we don't know exactly what to do, in fact. So this is a very, very, very difficult story. But back to the tandem autologous stem cell transplantation, to further consolidate, to further increase the quality of the response. The EMN2 study is very, very important, and I show you the design again of the study here. Induction with VCD or VMP, VCD single or tandem stem cell transplantation according to center policy. So Michele Cavo, during this meeting, and you should go to listen to him on Sunday morning, will report on the single versus tandem frontline stem cell transplantation results into the EMN2 study. And these are the pictures from the abstract, so nothing new if you already looked at the abstract. The PFS is better for tandem. OS also is improved with the tandem stem cell transplantation. And when looking at high-risk cytogenetics, no difference in the tandem stem cell transplantation arm with high-risk or standard risk cytogenetics, indicating that maybe tandem is very important to overcome the poor prognosis of high-risk cytogenetics. So, well, maybe we are going to discuss in the near future on the role of tandem stem cell transplantation. Is tandem back? Well, we are going to listen to Michele, and then it will be important to have this picture in mind, especially for overall survival. So, how we want to improve on these results? Because, as you see here, despite tandem stem cell transplantation, there is no plateau. PFS is decreasing over time, indicating that we are not curing any patient. So we need to improve on the results. So what to do? We can incorporate monoclonal antibody. And this is the Cassiope study that was performed in France and in the Netherlands. You can see that more than 1,000 patients were enrolled, and we have compared VTD, auto VTD versus the same regimen with daratumumab. And I invite you to come next year at ASH, and I will be able maybe to report on the first results of this Cassiope study. So this study is very important in the context of stem cell transplantation, including a monoclonal antibody. Why not also trying to improve on the regimen up front? And this picture is showing the KRD data without stem cell transplantation. The study was shown by Vincent earlier, but you can see that this is a longer follow-up with KRD without stem cell transplantation. But if you are adding stem cell transplantation to KRD, 2 phase 2 trials, but in yellow, clearly the results for PFS are outstanding with KRD stem cell transplantation. So 2 studies will be started very, very soon, and these studies are of utmost importance to my opinion. VRD plus or minus DARA and stem cell transplantation, and KRD plus or minus DARA and stem cell transplantation. So for sure, we are going to improve on the results with a very good induction plus or minus a monoclonal antibody. What our colleagues from Spain are doing, they are liking ixazomib a lot, and you heard this previously. They are looking, following stem cell transplantation, they are comparing Lendex maintenance versus Lendex plus ixazomib. And that's a very good study to my opinion, because here we can use a synergistic combination with an IMiD and a PI, and we have oral regimens available now. So this study is very important, and I hope that in the future we will have the demonstration that 2 drugs are very easily available and provided to an oral regimen can improve on the results of maintenance. So let's back to our case, in fact. The patient was treated with VRD, and that was your first proposal, times 4. He achieved VGPR, he received stem cell transplantation, achieved stringent CR, and we evaluated MRD, minimal residual disease, with flow cytometry, but with the new technology, 2 tubes, 8 color, what we are calling the Euroflow, next generation flow, and the MRD following stem cell transplantation, MRD negativity was reached at the level of 10 to the minus 5. So you are going to vote and to tell us, in fact, would you prefer, if you have to evaluate MRD, are you preferring next generation sequencing or next generation flow cytometry? So please vote. Okay. Bruno, interesting.
Okay. So we will need to find out why.
Yeah. So the patient reached MRD negativity 10 to the minus 5 following stem cell transplantation. He did receive 2 cycles of consolidation, stringent CR, but we looked at MRD negativity by flow, same technology, and now the patient is reaching 10 to the minus 6. So we are further increasing the quality of the response. When you want to evaluate MRD, are you using PET-CT as well in your practice? Yes, at diagnosis. Yes, at diagnosis and before maintenance. And yes, before maintenance. Or no. So please vote for MRD assessment. Okay, so only 1/3 of you are using PET-CT before treatment and before maintenance to look at the disappearance of the lesions. Very interesting. Are you using both MRD assessment within and outside the bone marrow with NGS or NGF and PET-CT? Yes, no, please vote. It's good to see the picture. Okay, interesting. So the patient was treated with LEN maintenance. LEN maintenance was proposed during 3 years and was discontinued due to GI toxicity and to fatigue. The patient has serial evaluation of MRD with flow during the maintenance phase. 1 year post-maintenance, MRD is negative. At the end of maintenance, 3 years later, the patient is still at the level of 10 to the minus 6. So, to your opinion, this patient is remaining MRD negative, 10 to the minus 6, 3 years 3 years following stem cell transplantation, at the end of maintenance. Do you consider this patient cured? This is at the end of maintenance. Okay, no, the majority of the cases. And only 10% of you are thinking that this patient is cured. Interesting. So, of course, we are going in the future to monitor the quality of the response. And Bruno and some colleagues wrote a paper, a very interesting paper in Blood, looking at the technologies that are not now available. And you know that we have next generation flow, NGS, within the bone marrow. We have also PET-CT. And the sensitivity level of both technologies are rather similar, with NGF 10 to the minus 5, easily 10 to the minus 6, and NGS that's the same. There are some differences. We need fresh samples for flow. We don't need fresh samples for NGS. We know that the availability of flow cytometry is very high. In all our labs, we are using flow. For NGS, that's more limited, let's say. So there are several differences, in fact. And what is the best technology? Do we need NGS? Do we need NGF? Do we need both, in fact? So this is the French study looking at frontline treatment in young patients. You know that patients were treated with VRD or VRD plus stem cell transplantation, and they receive 1 year maintenance with lenalidomide. And we looked at MRD before and after maintenance. We looked at MRD with 7-color flow, but also with NGS. And during this meeting, Hervé Avelloiseau, on behalf of the French group, will show the results of MRD by NGS at the completion of the treatment. And you can see that for those patients that are reaching 10 to the minus 6, the progression-free survival is really totally different as compared with those patients that are remaining MRD positive. So maybe in our hands, we are considering that the optimal threshold is 10 to the minus 6. Nevertheless, and I would say disappointingly, we don't have here some plateau. patients are still progressing. So many of them maybe are not cured. So is it related to the quality of the samples? And we know that for bone marrow assessment, especially with NGS, we need to have bone marrow and not blood and not a diluted aspirate. But also it may mean that high-risk patients here enrolled and reaching 10 to the minus 6 are going to relapse despite this very, very high quality of response. The Spanish group is also showing data during this meeting with next generation flow cytometry and not NGS. So what did they do? They proposed VRD, 6 cycles of induction, then patients were treated with stem cell transplantation, and they did receive a consolidation with VRD times 2 with serial assessment of MRD. And Bruno, during the meeting, is going to show that NGF is also able to reach the sensitivity level of 10 to the minus 6 or even better. And there is a very clear correlation for progression-free survival with the level of MRD negativity. And you can see only here those patients that are not reaching MRD negativity, and many of them are progressing very, very quickly. So please go to and listen to these important data. And we have now plenty of comparisons of NGF, NGS that will be available. What about imaging techniques, in fact? In the same French study, VRD, stem cell transplantation, VRD without stem cell transplantation up front, we looked at NGS, NGF, but we looked also at PET-CT, at diagnosis, following induction, and before maintenance. And we were able to look at a group of patients that were both negative with flow cytometry, but also negative with PET. And when you are reaching negativity with the two technologies, within and outside the bone marrow, the PFS of those patients is really, really impressive with a plateau. Some patients into this group may be cured when you are looking at the progression-free survival data. On the other hand, when you are looking at patients with either flow positivity or PET positivity or both positive, you can see that the outcome is totally different. So the message here is maybe that we need to look not only within the bone marrow, but also outside the bone marrow, and the two technologies are probably complementary. So what we can say, what are the validated points regarding MRD assessment? We know that MRD negativity is a surrogate for progression-free survival. And this was really clearly demonstrated in a meta-analysis recently published by Nikhil Munshi. It is also a surrogate for overall survival, at least for frontline evaluation of MRD. That was also true in this meta-analysis from Dr. Munshi, recently published in the JAMA journal. NGS is standardized. Flow cytometry is also standardized with the new Euro technology, 2 tubes, 8 color. And as mentioned previously, we are thinking that PET-CT and either NGS or NGF are complementary. And this MRD assessment is very useful to compare treatment options. Vincent mentioned that KRD is currently comparing with VRD into a very interesting and very important study in the US. We are going to see what the MRD level will be with KRD and what it will be with VRD. And we will be able to look not only at the response rate with conventional electrophoresis and immunofixation, etc., but also at the MRD level. But many, many issues are not yet solved. What is the optimal threshold from a patient point of view? 10 to the minus 5, 10 to the minus 6? For prediction of overall survival, that we don't know. No one is knowing. Do we need to perform both NGS and NGF? Are able to reach the same sensitivity level of 10 to the minus 6? Probably. No one is doing this. And we need prospective two technologies. More and more, we are now speaking about sustained MRD negativity. Like in CML, you know that in CML, when a patient is MRD negative at the molecular level during 5 years, 6 years, you can stop Gleevec, and then half of the patients are not progressing. Are we able to speak about these assessments multiple myeloma, we sustain this concept of sustained MRD negativity. So are we going to perform bone marrow aspirate every 6 months to check during a maintenance treatment if the patient is MRD negative or not? This is not routine practice at all, for sure. And what is the meaning of MRD, the loss of MRD negativity? Your patient during a maintenance phase is at 10 to the minus 6. Then a subsequent evaluation, 10 to the minus 5. Is it a loss of MRD negativity? This patient is going to progress very quickly? Do we need to have only one time point to assess the loss of MRD negativity? No one is doing this, in fact. Obviously, PET-CT is not yet standardized, and we need to work. There is currently many efforts in Europe to try to standardize PET-CT, and we know that PET at diagnosis is only positive in 90% of the patients. Not all patients are positive despite bone lesions. So we need also to improve on the technology of PET and find maybe the best tracer for PET-CT evaluation. Are we able to use MRD to change the treatment, to alter therapy? During the maintenance, MRD is becoming positive. I am going to add to lenalidomide, I don't know, an ixazomib, for example, or I'm going to add another drug. Well, no one is knowing this, in fact. We know also that many groups are working on blood-based MRD assessment because we need to perform bone marrow aspirate. Okay, we are doing this in acute leukemia very, very well on routine practice, but we are not used to do this in myeloma. Maybe we need to develop blood-based MRD technologies that will be really more simple to evaluate the response, etc. And are we able to use MRD as a valid endpoint for drug approval? This is another very important point. We know that with the ongoing trials, the overall survival will be 5 years, 6 years, 7 years. The PFS in the relapse setting may reach 50 months. So are we able to wait for 10 years, an overall survival benefit before drug approval? Maybe we can use MRD as a surrogate for drug approval. But to date, it is a question mark. So are we going to have new trials that will be able to help us in solving these issues? In Cassiope, the ongoing study with VTD DARA, stem cell transplantation versus VTD alone, we are going to look systematically at flow cytometry, NGS, before and after treatment. We are going also to assess PET-CT before and after treatment. So we will have the answers about the best technologies, what we should implement into our future routine practice. The Spanish group is also running this study, and I mentioned it previously, Induction with VRD times 6, and the abstract will be presented by Laura Rossignol on the results of VRD times 6 in terms of MRD negativity and response on Saturday. Unfortunately, that's an abstract only. To me, it was deserving an oral presentation because the number of patients is very, very high and the quality of the data is very good. And they are assessing MRD following stem cell transplantation, following consolidation. They are doing maintenance with Len or Len-Ixa, and MRD is assessed annually. And following 2 years of treatment, for the first time, we have a treatment that is changing according to MRD positivity or MRD negativity. Negative, you stop. Positivity, you are still proposing a longer duration of maintenance. So this is what has to be done in 2 clinical trials to assess the value of MRD with flow cytometry, with NGS, etc. And this is the ongoing Italian study comparing Carfil-Lendex KRD versus Carfil-Cyclodex before and after stem cell transplantation. They are also proposing a maintenance with Len alone or Len plus Carfil. So very interesting study. Many patients were enrolled. The study is completed now for enrollment. But our Italian colleagues are also looking at several time points, NGS, NGF, but also PET-CT. So all these 3 trials are examples of what should be done to know clearly the role of MRD in the future. So what can be proposed, maybe in something like 5 years from now, to try to cure patients maybe? A quadruplet induction, including a monoclonal antibody, stem cell transplantation, same quadruplet with consolidation, and if MRD is negative, maintenance, serial assessment, and if negative, maybe we can start the treatment. So this is one proposal. Maybe that's a dream, and Jesus loves to dream. So Jesus, you're okay with this proposal? You will tell us. And I would like to thank you for your kind attention.
So thank you so much, Philippe, for this excellent presentation, raising some very, very important points for thought and discussion. And so, first of all, we will show you what did the panel think about the answers to these questions. So, first of all, for the treatment, the optimal treatment plan, we can see that there is a uniformity, in fact, that we selected VRD. Philippe, and partly because of his trial, I think, I mean, they have VTD or VRD with transplant and consolidation and maintenance. And so really fairly uniform on that particular point. If we go forward to the MRD assessment, what did we think about that? Would you prefer NGS or NGF? You can see that NGF is decisive, the others are unsure. So we can maybe have some comment about that in a moment. As far as the impact of 10 to the minus 6, going from the transplant, consolidation, and then achieving MRD negative at 10 to the minus 6. Recommendations, would we use PET-CT in addition? And Vincent is not recommending PET-CT. So maybe we should have him comment about this right away.
Oh. Well, you're getting into, like, if the patient clearly has multiple myeloma and lytic lesions on skeletal survey, I don't even think we need CT survey. But if the patient doesn't have lytic lesions on skeletal survey, and I'm not sure of how much disease there is, then I do a baseline CT survey routinely in all our patients, if available. The PET-CT scan, we are reserving.
So you're saying that you really don't see value in a baseline PET-CT. Is that the first part?
If I already know the extent of the disease in the patient, I don't think why I would need to add another PET-CT to the cost of the patient's evaluation.
What if they have extramedullary disease, possibly?
I think somebody needs to show me the incremental value of the PET-CT in a patient like that.
Okay.
If the patient is a patient where I don't know what exactly is going on, like it's kind of a smoldering myeloma, solitary plasmacytoma situation, or a patient where I'm not confident of the disease burden, then I will certainly do a PET-CT. This is what we are recommending in UpToDate. There's a very detailed discussion of this. If we have the luxury of infinite resources, yes, of course, do every test. But we don't. And so we have to pick and choose when we can do. And that's part of the consideration.
Okay, so any follow-up comments on the right?
Yeah, I think the cost of a good diagnostic test is really very low as compared with just one cycle of treatment. And if a good diagnostic test helped me to drive the treatment, for me is most important. Probably Bruno can expand on this, but in the Spanish trial conducted by Laura and Joan, the 10 to the minus 6 patients did very well, but some of the patients have already relapsed. And I asked Bruno to look to these relapses. 5 out of the 6 patients have extramedullary disease at diagnosis.
So Bruno, you want to comment further on that?
And I think if you don't realize of these patients, then you are going to miss.
I would echo on that it may be that in the future it will be not only a diagnostic test, but also a monitoring test. And I think that for accurate monitoring using image, the baseline picture will be very informative. So this is something that should be considered in the future.
Okay. Yeah, Philippe?
We do also have several trials that showed very clearly the role of extramedullary disease evaluated by PET-CT at diagnosis for overall survival
Yes.
prognosis. And that was, first of all, published by the Arkansas group, by the Italian group as well. Yes. In our study, we looked at this, and it was a prognostic factor for overall survival as well, an independent one. So I think that when we are able to assess extramedullary disease at the time of diagnosis, we know that the prognostic will be different, and maybe we can speak about tandem stem cell transplantation now for those patients. I think that's quite important. Well, Vincent is always very, very provocative, but he was co-author of the PET consensus paper published by Michele and Elena. And well, he said that, yes, there is overall survival data according to extramedullary disease. So Vincent, can you comment on this, please?
No, I'm just saying that, you do have, sensitivity is only one part of the equation. Yes, you can have more and more sensitive tests, but more and more sensitive tests don't mean that you've proven the value of that test. That is requiring a different standard of proof. All I'm saying is that not every single newly diagnosed patient with myeloma needs a baseline PET-CT, because I already know the diagnosis. I've already got a very good estimate of the disease burden by other methods in the vast majority of patients. There are patients where I'm doubtful, I will do the PET-CT. And that's the very first thing we talked about.
All right. So we don't have it as part of this, but we need to have the next time if we change the vote on the panel at all. Maybe not, I think. Okay, let's keep going. So are you using NGS and plus MRD monitoring and PET? And of course, we continue to have a no from to Vincent, but I'm assuming that this is because of the PET-CT probably, right? Okay. And then here we have a follow-up. Do you consider this patient cured? And it was clear that we really are a little uncomfortable to make a statement about a patient being cured. And so we're unsure, except for Vincent, who is a decisive no. Maybe some of them are cured, don't you think? Or Vincent, what does this no mean? I mean, I think that we're feeling like maybe hopefully we're starting to cure some patients. Would you concede that?
Well, the implications are so huge. That's why I don't want to use the cure word prematurely. When you say you can potentially cure a disease, it takes on a whole different meaning than saying occasional patients are cured. There's a very big difference. I will tell you, I had an abstract at this ASH with over 800 patients, which didn't even make it to a poster presentation because the conclusion said we are not curing myeloma. People don't want to hear that, but that's the truth. The truth is that if I get multiple myeloma, or somebody younger than me, let's say 40 years old, gets multiple myeloma, can we really look them in the eye and say, I can cure you with a certain percentage of certainty, like we do for diffuse large B-cell or Hodgkin's disease? No. We looked at all patients at Mayo treated in the last 10 years who were less than 40 years of age, who had multiple myeloma. And there is a continuous follow-up. There's a relapse that happens with time. Yes, you will be MRD negative for 5 years, but many years need to go by before I know that it's a curable disease.
All right. So I mean, do any of you think that we could? Do you think we are curing some patients right now or not?
So the difference again, Brian, is that's a different question. Are we curing some patients? We were curing patients with melphalan prednisone. Bob Kyle will tell you there were 3% of patients cured with melphalan prednisone. That's different than saying whether myeloma is a curable disease.
Okay. Yeah. So if we have MRD at 5 years, would this be good?
I don't know.
I mean, definitely will be good. And I fully agree with Vincent that it's difficult to give an estimation of how many patients can be cured nowadays, because you need 10 years
Right.
follow-up. I mean, we are talking about 10% cure in the era of the autologous transplant with chemotherapy. Probably we are talking about 20, 30%, but it's in the area of bortezomib, thalidomide, dexamethasone. Now we have completely different drugs, but the follow-up is very short. I mean, we need time.
Right.
It's also the definition of cure.
Yes.
I think that in a disease that in
Yep.
several patients takes 20 years to develop, I believe it's much more disseminated than any technique really allows to see. When you say there is no disease, you are saying that you are not seeing any disease, but eventually there might be some. However, it may be into such a low level that it can be kept under control for several years. I think this kind of definition is more appealing than the word cure.
So we have to move on. So a lot of open issues were presented and commented on by Philippe. I think that we don't have a lot of time to comment on those. Clearly, some of the new protocols that you showed us will help us to understand a number of these things, including PET-CT, which will be done at baseline in these studies, which let me just comment, that is remarkable that this will be possible in the Cassiopeia trial. That's wonderful that that will be possible. Okay, so let's bring it back here. Before we go to repeating your answers, any strong questions or comments from anyone? Anyone want to voice anything about curing, about MRD testing, or yes?
Yes, regarding the PET-CT issue.
Yes.
I treat in India, developing country, and that's where Vincent also had his training. So there's so many PET-CTs in the extramedullary pickups where there is infectious causes. I've seen SUVs of 10, 12, 16 which turned out to be tuberculosis or just an infection. So unless you define that how we interpret the PET-CT is whether infection can present as myeloma. And in fact, I have done those biopsies repeatedly, and many of them turned out to be infectious. So really you have to be careful regarding that PET-CT interpretation.
Right, so that is an important caveat, yes, that you need to be sure. Okay, all right, I think let's go ahead and see if we've changed any opinions here. Okay, so in this case, you had selected VRD consolidation transplant. Let's see what happened here. Let's vote again. So you had a choice. If you want to pick again, VRD transplant, or possibly VCD, or even tandem. If you could vote again, please. Okay, it even so, Philippe, you even increased your your audience from 63% to 78%. Yeah, so we didn't really comment on this, but I mean there was a decisive acceptance of the role of a single transplant. Do you want to comment?
Well, I'll comment on number one, on the VRD consolidation. I picked that as well because there was no option without the VRD consolidation.
Yes.
But I really don't think that there is a proof that the VRD consolidation adds anything from the BMT-CTN trial. So my standard is VRD times 4 MEL200 len maintenance. That's the standard. The VRD consolidation is really a big if, and it's an extra 2 months of therapy for patients who've just had a transplant. If you're going to do that, just prove it to me better than just possibly one positive trial. I mean, the BMT-CTN asked that question and didn't find any benefit, zero benefit. Number two, the tandem transplant is a very big confusion. I have to wait to see Michele's presentation to make a decision because it is just right at odds with the BMT-CTN trial. So the US trial found no benefit to tandem transplant in the era of VRD induction and len maintenance, while the EMN trial finds a benefit. So I really need to go through the data really carefully with a microscope to decide, you know, is that second transplant needed? Maybe it's needed for the high-risk patients. We have to really examine for the standard risk, do we really need it?
Right. No, that is a consistent observation from the Bologna group. And so I guess we do need to see it one more time to know that. Okay, so let's go forward again. Asking questions about MRD here. We can go forward. It's not going forward for some reason. Oh, there we go. All right. So let's see again, do you prefer NGS or NGF? So fairly simple question. It was actually split around 40% the last time. So let's see what we have here now. Please vote. Okay, it was split around 40% again, although actually NGS dropped. This is interesting. So there was a drop there in NGS. So NGS went to unsure. Interesting. NGF went up a couple of points. Okay, interesting. All right. We don't have time to analyze that. We have something else. Okay, let's keep going. The final points here, if go forward to the question. Okay. All right. Ask again about cure. Okay, so if you don't mind just to answer this one more time. The first time you were very uncertain the patient was cured, but let's see what you think now. Oh, so actually, yes, improved. Oh, no, sorry. Yes, dropped. Okay, I'm so sorry. So you have a 7% improvement there, Vincent. Yes. All right. Okay. All right, well, thank you for that. That was certainly quite interesting in terms of the role of imaging and whether patients can currently be cured or not. Really a very, very important point as to how we might define that longer-term treatment benefit. And so moving into the relapse setting, I'm very pleased to welcome Jesus San Miguel to introduce the topic of first relapse and what would be treatment options in that setting. So please welcome Jesus.
Thank you.
Right behind me.
Okay, good afternoon. Probably you are a bit tired at this time. You know, until year 2000, only 2 drugs were clearly effective for the treatment of multiple myeloma, melphalan and corticosteroids. But since then, 9 drugs has been approved, and there are multiple potential combinations of these drugs. These are very good news. However, the accessibility to these regimes is not the same in all regions. And probably there are so many potential combinations that to make a right choice, you need a compass. When we talk about personalized medicine, this is the time. You need to consider when you are in front of a patient at the time of relapse, what are the disease-related factors, the type of relapse, cytogenetic, extramedullary disease, patient-related factors, the efficacy, which is critical, of prior treatment. This is not working. The efficacy and toxicity of prior treatment, as well as the further options. This is critical when you are going to make a decision on the treatment of relapse. The second message that I want just to give you is that the best possible treatment should be used upfront or in first relapse. Otherwise, you are spoiling part of the money. Please concentrate at diagnosis and first relapse. This is not working, please.
Can we get the arrow to work, please? Yes.
Okay.
It was working, but...
I will drive you now through 3 different clinical cases in order to understand the decision at the time of relapse. The first corresponds to a 60-year-old man that was diagnosed as IgD myeloma, stage 3. Is working or not? It's working now. No, it's not working. Yeah. He received VTD for 3 cycles, followed by autologous transplant, and 2 years of maintenance with lenalidomide, and the patient relapsed 18 months after discontinuing lenalidomide. Then, in this particular case, I think not. My question is, how would you treat this patient? Would you rescue the treatment with a second autologous transplant? Would you use an allogeneic transplant? You will treat with anti-CD38 antibody combination until progression. Will you offer a clinical trial, or are you unsure? Please vote. It's not working. Please ask. I need that.
It's working. Let's see. Find it.
It's not working. I need this. To press? To press? No. Come here. Okay, these are the answers. Half of you suggested rescue treatment followed by a second autologous transplant, and the other half of you preferred not to go to the transplant and to treat with anti-CD38 combination until progression, which is fine. I think the decision in this patient, according to our personal opinion, is that this patient has relapsed almost 4 years after diagnosis. Then in this particular patient, I will go for the third option. I will treat with a new second autologous transplant. If the patient has had a biochemical relapse, I will repeat probably the initial approach, but if it's aggressive, I will probably offer this patient KRD or KRD plus DARA and the second transplant. By contrast, if I have in front of a patient with an early relapse, that the patient relapsed less than 1 year post-autologous transplant, my goal is to try to overcome drug resistance. And in this particular case, I will go for the best possible treatment, aggressive treatment with non-cross resistant agents, such as KRD PACE or DARA in addition, and then I will, probably this is the only context in which I will consider the allotransplant until we have the CAR T-cell therapy in these patients. Now let me move to the second case. A 70-year-old man that was diagnosed with an IgA, a stage 1 myeloma, and moderate renal insufficiency. He was initially treated with a bortezomib-based regime, BMP, for 9 cycles, and the patient achieved VGPR that lasted for 2 years. In this particular case, how do we treat at time of first relapse? To retreat with a bortezomib combination, lenalidomide-dex, carfilzomib-lenalidomide-dex, ixazomib-lenalidomide-dex, daratumumab-lenalidomide-dex, and sure, please vote. It's not working. Okay, most of you have chosen daratumumab, lenalidomide, dexamethasone, and also 1/4 proposed carfilzomib, lenalidomide, dexamethasone, which is very interesting. Also, some people consider retreatment. Let me try to show you what is the data. This patient, after bortezomib induction, without lenalidomide maintenance, what is approved in most countries is lenalidomide dex until progression. The PFS is 15 months. However, this standard of care, because this has been approved as a standard of care, has been recently challenged by the triplets, combining lenalidomide dex with proteasome inhibitors, KRD, IXA-RD, these are the PFS, or monoclonal antibodies, ILO or daratumumab. But we are in a context that we should not forget that in many countries this is not affordable and there are economical constraints, and I'm going to discuss this data. First of all, the two trials that have compared the three drugs based on a proteasome inhibitor plus lenalidomide dex versus lenalidomide dex. As you can see here, in both cases, the CR is improved with the triplet, with the addition of the proteasome inhibitor, 31% and 11% complete responses, and also there is in both trials a prolongation of PFS of 8.7 and 5.9 months. In addition, in this meeting, Keith Stewart is going to show in the KRD versus RD study that there is also not only a prolongation in PFS, but also a significant benefit in overall survival, 8 months improvement in favor of the triplet. Regarding the toxicity of this triplet, if you look to the treatment discontinuations, it's almost the same. It's not higher with the triplet, and the only caveat that you should be aware is that the cardiovascular toxicity that is increased with the addition of carfilzomib, but we are learning how to manage this. And also I want you to pay attention about peripheral neuropathy. It's 2.6, very low incidence of peripheral neuropathy with this proteasome inhibitor. Regarding the other randomized trial based on a proteasome inhibitor, ixazomib plus lenalidomide dex, regarding the toxicity, as you can see, the grade 3-4 toxicity is almost the same in the triplet than in the doublet. And in fact, once again here, we have a very low incidence of peripheral neuropathy. But probably the main revolution, the major revolution came with the monoclonal antibodies, completely different mechanism of action, and we have now several monoclonal antibodies that can be used in multiple myeloma. The first one was ilotuzumab against SLAMF7. It not showed any activity as single agent, only disease stabilization. However, in combination with lenalidomide dex, as compared with lendex alone, it has shown a significant benefit in progression-free survival, is 5 months improvement, and also there is a benefit in the overall survival, indicated that the immunomodulation in this patient take time, but is clear benefit in the prolonged overall survival. This regime was very well tolerated. The addition of ilotuzumab did not increase the incidence of adverse events. As you can see, infusion reaction occurred mainly in the first infusion and were grade 1 or 2. But probably the most striking data was reported in this study in New England Journal of Medicine, in which lenalidomide dex was compared with daratumumab lenalidomide dex. I would like just to call your attention about the complete response rate that is in the top part of the, here I have the arrow now, is 51% versus 21%, with a significant improvement in PFS, that is 17 months in the control arm and has not been reached in the data RD. And this probably, the explanation for this significant benefit is in the minimal residual disease analysis, that as you can see, in a sensitivity to 10 to the minus 6, 13% versus 3%, 10 to the minus 4, 34% versus 10%, achieve an MRD negative status that correlates very well with the survival. Regarding toxicity, once again, we have that the treatment discontinuation is not higher in the DARA arm. We have observed an incidence of infusion-related reaction, but mainly, again, occur in the first cycle and were really manageable. Then, in this patient that was induced with bortezomib, melphalan, prednisone, he not received lenalidomide. Lenalidomide could be an option, but the data indicate that triplets, particularly probably DARA-RD or KRD, are clearly better options. However, not everybody has access to this drug, and there are economical constraints in many countries, and you can consider, since it was very effective and has a treatment-free interval of almost 2 years, retreatment, again, with a proteasome inhibitor such as VTD could be used in this patient. But I would offer in this patient always lenalidomide dex because he has not been exposed yet to an IMiD. And in order to improve the efficacy of lenalidomide dex, why not to add cyclophosphamide? And why I say this? This small study conducted by the Dutch group in patients that were lenalidomide refractory has shown that when they are treated with lenalidomide, cyclophosphamide, and dexamethasone, the overall response rate is impressive, and the PFS is 12 months. And at this meeting, there are going to be presented data on pomalidomide that the addition of cyclophosphamide is able to rescue patients and having very good result. Brian Dury is going to expand on this. But my message is that probably in this relapse setting, the addition of oral cyclophosphamide 50 milligram to Lendex could be a good option if there are economical constraints. Okay, now let me move to the third clinical case. It's a 82-year-old woman that was diagnosed with IgG-kappa, stage 3 myeloma, with a lesion p53 in 20% of the plasma cell. She achieved a VGPR with lenalidomide dex, but on month 24 of continuous treatment, she developed rapid disease progression. And now, please vote about these options. In this patient, when they progress under Lendex, will you use bortezomib dex, bortezomib melphalan-prednisone, carfilzomib dexamethasone, carfilzomib pomalidomide dexamethasone, dara bortezomib dex, dara pom dex? Please vote. Okay. The majority proposed dara bortezomib dex, followed by dara pomalidomide dex. Very few people propose other options in this patient. Okay, let me again try to drive you. This patient that has become lenalidomide refractory is in first relapse. Probably the obvious choice will be to offer him bortezomib dexamethasone. And this is what we use and we propose until very recently. But we have data on carfilzomib dex that I'm going to discuss. And on top of this, we have data on triplets based on bortezomib, ILO-VD, dara-VD, and panovinostat-VD. But again, don't forget about the economical constraints. This patient has received Lendex progress, and why not to add to the bortezomib dex an alkylator? I will go through this data. First, we have one head-to-head randomized trial in which bortezomib dex has been compared with carfilzomib dex, and the data clearly show a benefit for the second-generation proteasome inhibitor. It's almost double the PFS, and it's also associated, is the second study based on carfilzomib that show benefit in overall survival in this study, and also double the complete response rate. What about daratumumab bortezomib dex versus bortezomib dex? The CASTOR trial has shown also a significant benefit in PFS, median PFS for the triplet 16.7 months versus 7.1 months in the doublet bortezomib dex, and this is probably associated or reflected the benefit in terms of response rate. The CR rate is 28% versus 10% in the doublet. In this meeting, Sagerlonial is going to present very attractive data on 85 patients receiving, at the time of relapse, daratumumab carfilzomib dexamethasone, 84% overall response rate, and a PFS at 12 months of 74%. We have also opportunity with a different class of drug, the histone deacetylate inhibitors, panovinostat. Panovinostat, in combination with bortezomib dex, has shown to be superior to bortezomib dex, 4 months difference in PFS, but this difference is clearly increased if you consider patients that has been previously exposed to both bortezomib and IMiDs. The difference here goes almost to 8 months in benefit of the triplet. But once again, I don't like to forget countries in which these combinations are not affordable. And for this reason, in this patient that has been exposed to lenalidomide dex, I will not use bortezomib dex because I know that PFS is relatively short. I would add a third agent, an alkylator, because the PFS increased to 16 months, that is similar to the ones that has been reported with the new drugs. And there are 2 abstracts in this Congress that show one is a comparison VCD versus KCD. KCD is superior, but with VCD you have 68% response. Another abstract, VCD versus LACD, again 68% response and PFS of 16 months. Please don't forget that with some cheap combinations you can get also good results. What are other factors influencing our decisions? Age, type of relapse, and number of prior lines of therapy. This can be a complicated slide, but I think it's an important slide. What I have done here is I have took all the triplets compared with the doublets, and I have compared the outcome, the hazard ratio, according to age. This study compared less than 65 versus more than 65. Here you have less than 75 versus more than 75. The message is that the data combination in both data Lendex and data BD clearly indicate that age is not a problem. You can really overcome the negative impact of age because the outcome, the hazard ratio, is the same. And also, the same or even better occurs in the Endeavor trial that is KD. By contrast, with the KRD in the very elderly population, the outcome is not so good, probably is quite toxic in this context, and will be better in here to use the KD. What about prior lines of therapy? Again, the data studies are associated with very good hazard ratio, but let me explain to you what I want to say. Here, you can see that the hazard ratio for data RD is even better with 2 lines of therapy than in patients relapsing just after 1 line of therapy. By contrast, in the Castor, the patients that benefit more are the ones that are relapsed after 1 line of therapy. And again, here, you have that in the Aspire, the number of lines of therapy does not impact. By contrast, impact a bit in the Endeavor trial. Then I would suggest that it's better to use, if you are going to use data VD in first line, that instead of second line, the same apply for KD. By contrast, the triplet KRD and data RD becomes very active also in second or subsequent lines of therapy. And what about cytogenetic abnormalities? Again, here we have the standard risk and below the high risk. If you look in most of the studies, you can see that the hazard ratio is clearly in favor of the triplets, but we want to concentrate on the combination that is able to overcome the adverse prognosis. To overcome the adverse prognosis means that the high-risk patients do as well as the standard risk. And here we have only the IRD that do even better than the standard risk. Here you have that in the other, usually the standard risk do not as well, the high risk do not as well, the standard risk patients. And I think now I would like you to focus on the 2 last slides because are the conclusion. And the conclusion are always very important in presentation. And I'm sure that you share with this dog the message, but particularly with my grandson. But he has a very clear ideas about this presentation. Thank you very much for your attention.
I'll go ahead, yes.
You go.
Yes. So thank you so much, Jesus, for this excellent presentation. And also, emphasizing and bringing into play the access to these relapse regimens and the economic factors, which really does impact the way that you might answer some of these questions. And so, first of all, I'll go ahead and show you what the panel did for these different questions. And so this first case with translocation 414, VTD, relapsing after 18 months following LEN maintenance. And what did we say? Well, I think that the DARA data are obviously very strong and have very much influenced, or I would, in some cases, dominated our decision process. Although Philippe does say that it would be okay to consider the rescue stem cell as well as Vincent. Yeah, so would someone like to comment on the pros and cons of the repeat stem cell versus the DARA? Would you like to comment on that?
Well, I think that there was a consensus paper written on how to use salvage stem cell transplantation, proposing to do this salvage transplantation when the first duration of the response was something like 12 to 11 months. I think that's not enough.
Okay.
In my department, we are trying to use at least a 3-year duration of response.
Okay.
If you have a long response, then you can re-challenge with the stem cell transplantation.
Yeah.
Yeah.
Although the answer that I choose was the double possibility. Again, if I think in an economical constraint, this patient has relapsed almost 4 years after diagnosis, I think the the salvage transplant after reinduction will be probably the best option for them because we'll associate it with longer PFS.
Vincent, you want to comment? Yeah.
Yes, I agree with what Jesus and Philippe just said. I mean, the 3 years is what we use as well, as long as the patient's on maintenance, because you expect at least 4 years, and if they get 3 years at least, then a repeat transplant is very reasonable. I want to make one more point. The transplant is the one that is really limited by age and performance status much more than daratumumab is. You can always do the daratumumab once the second transplant doesn't work, but you cannot do it the other way around. In many patients, they might become too old for the transplant.
Right.
So if you think the transplant's given them a very long PFS the first time,
Yes.
maybe try that first. The DARA will always be around.
Right. Okay. So then the next point, an older patient with the VMP, the Spanish favorite, for 9 cycles that lasted for 2 years. And when this patient relapsed, we all picked DARA Landex for this. And so I think that those data are obviously quite strong. For the next case, an older patient with a P53, Landex, and then rapid disease progression. Again, since the patient had been on an IMiD, we switched to the DARA Velcade Dex, and Jesus showed rather clearly the impact of these different regimens related to the cytogenetic risk. Okay. Yes, so these different points. I'm just going to skip over these. And before we go back to the audience, any other broader comments? I think that the point that you made, Jesus, about what would be reasonable options when DARA might not be available or some of these drugs are not available. Obviously, the results are not quite as good, but with response rates of like 68%, for example, versus maybe a little bit higher if you happen to have access. You want to comment on that a little bit?
I was really surprised with the data of adding cyclophosphamide to lenalidomide dexamethasone. The Dutch study, in fact, when I reviewed this paper, I was really in doubt of the so positive results. But now we have with pomalidomide cyclophosphamide dex very solid information, and the same for relapse. If you are living in a country you have not options economic, and you have an economical constraint, the patient has received Lendex, the patient relapse, bortezomib dex is probably insufficient. But if you add Cyborg-D,
Right.
cyclophosphamide oral, 50 milligrams per day, you can increase double the PFS. Then I think this is an option in those countries.
Right. Okay, so questions or comments from the audience? Yeah, this gentleman right here, if there's a microphone, please.
Yeah, I'm over here to your right, in the back.
Oh, okay.
Yeah. So,
Okay.
yeah, I'm Tony Blau. I'm a hematologist. I have myeloma. I have a startup called All4Cure. And the thing that I wonder about is when you become MRD negative, how many myeloma, which I've fortunately achieved,
In the relapse setting, are you talking about?
after an auto transplant, allo transplant, 1 year after the allo transplant, for the first time MRD negative, 6 months later, MRD negative again.
All right.
I'm wondering how many myeloma cells could still be lurking around in my body. And if I do a back of the envelope calculation, and I think people estimate that our bodies have 37 trillion cells, and if you put 1 to 2 trillion in your bone marrow, that still calculates, if you have a 1 out of 10 to the 6th sensitivity, I could still be hiding easily 1 million myeloma cells that we would never detect. And so I guess, and I don't have a great answer for that other than time. I think over time we'll see whether I'm cured or whether I have 1 million myeloma cells left. But I wonder what you guys
Sure,
think
so
about
this
that.
is obviously a very, very central point, and I know that this is something that Bruno has been quite worried about recently, even with the 10 to the minus 6 sensitivity, where you can see these curves with a little bit of what seems like maybe linear relapse, which is still occurring at that 10 to the minus 6 level. So you want to comment on that, Bruno?
Well, it's a very, very important point, and it's not really a question, it's a point, a message, and a very important one. I think that really echoing what was said, if you start with 10 to the 12 or 10 to the 13 in tumor mass, really defining an MRD negative result even with a limited detection of 10 to the minus 6, which is what the next generation techniques offer, you can still have several tumor cells. And I would say that given the allogeneic stem cell transplantation, I would say that it's particularly important to combine a technique that measures MRD in the bone marrow flow or sequencing with, again, an imaging technique. We have seen in the past, and we have reported this a few years ago, that the only setting in which we struggle to see a clinical benefit after an MRD negative result by flow cytometry was in patients in CR after an allogeneic stem cell transplantation as a salvage therapy. So definitely there, I would recommend using both cellular and an imaging method. Realizing that an MRD negative result is a surrogate for clinical benefit, it should not be considered as a surrogate of cure. And also the importance of sustaining that MRD negative result over time. I think that a single snapshot, a single picture is not enough if you want to predict the future at the long term.
All right, so unfortunately we have to go ahead. So let's just ask these questions again and to see if any of the selections have changed. So this first case, the 414, and then after land maintenance, get this. How would you treat this patient? And we talked about rescue versus a CD38 approach. Let's see what people think now. If you could vote on this one. Okay, so it seems that our discussion did push the second transplant a little bit to the right, and it actually, what did it do? It decreased the use of clinical trials, is what it did, yes, but certainly increased the selection on second transplant. So interesting there. So let's go to the next point, VMP, and then follow-up options. Okay, how would you treat this patient? Retreat, or actually a variety of options. If you could go ahead and vote on this one again. Dara wins out on this one. Really, yes. Well, the data are really rather strong. Carfilzomib also dropped down, and ixazomib, yes. Okay, interesting there. Let's keep moving forward. This is a patient. How would you treat? Let me go back. I'm so sorry. There we go. So this is a patient who had a P53, VGPR, and then 24 months, and then developed rapid progression. So lenalidomide, and then in the setting of P53. And what would you pick here now? And I'm not sure what that number 5 was. That's Dara. Oh yes, it's okay. So Dara is winning out very, very strongly. Yes. Improved by over 20%. Okay, well, it's hard to argue, I'm afraid. Yes. And so finally, we have another one? No. Okay, well, thank you for your answers on that. Yeah. And so I have the honor to be the presenter for this last session, which is a little bit different in that it's influenced both by access to approved drugs, which can be options, the economic factors, and then also access to a whole range of trials which may be available in different parts of the country or different parts of the world. And so I'll ask you to consider what I'm presenting in a slightly different way in this setting as we go through. And so if we take a look at the first case, I thought that to start out with, in terms of looking at resistant disease, it would be helpful to consider a standard risk patient treated with Revdex, who did achieve an excellent response, VGPR, and then received len maintenance for 2 years, but relapsed on maintenance. And it was elected to switch this patient over to Velcade, bortezomib sub-Q, which did produce a partial response, but was followed by a clinical relapse. And so you have exposure to len, exposure to Velcade with clinical relapse. So the question is, how would you choose between these different options? So a doublet pomalidomide dex, pomalidomide cytoxin dex, Dara with pom dex, a carfilzomib combination with len or pom, or even go straight to a clinical trial. So if you could select among those options. So number 3, yes, and so clearly daratumumab is winning out, and as many of you probably know, the Dara-POM combination was approved, as well as the Dar-Rev and the Dar-Velcade, with a smattering of selections in the other choices. Okay, so let's move forward. What I want to do is just to consider what are the options as we move forward into the relapse refractory state. And so this is the normal pattern of disease that we consider. What's happened over the years is that we have much better and longer options in that middle part of the disease. These middle relapses, 1 to 3 relapses, are much better than longer. But unfortunately, we still do reach this last phase where patients do become refractory. When we think about these relapsing patients, there are differences. If the initial remission was long, favorable cytogenetics, if the progression is biochemical versus clinical, the age of the patient, obviously the worst factors, the short remission, the cytogenetic abnormalities, and also low platelets, plasma cell leukemia, and then if you happen to have access to GEP. We need to consider at this phase of the disease the patient factors, what's the age of the patient, and these various clinical factors that we pay attention to, as well as also looking at the clinical factors, the length of the response, the genetics, etc. And so it is possible to come up with an algorithm like this. I show this, and I'm going to break it down in just a moment, but I think that as you're looking at a relapse and refractory patient, it is very important to think about how long was the initial remission versus not. And so the patients who have that shorter initial remission, we do need to think about that differently, focusing possibly on a triplet therapy, maybe a repeat auto transplant, but less likely, and even considering a clinical trial. Conversely, if you look on the left-hand side of the slide, you could be considering some other options. So if you look at the bottom there for relapse therapy, you could be easily considering a doublet versus a triplet. And as you move forward into the disease, we have evidence for several triplets. And so I include KRD, ELO-LD, ixazomib, and then, of course, the DARA combinations with len and bortezomib. And so if we look at the bottom part here, just in a little bit more detail, the decision really is based upon whether we feel that a doublet is reasonable, although we have in many cases good comparative data that Jesus summarized so nicely, showing that in most instances a triplet has better PFS and overall survival versus the doublet. And so the thing I want to illustrate here is that on this slide, this shows a summary of the combinations. And on this, you have doublets and triplets. And it really is kind of all over the map. And so on the left there in red, I've highlighted the triplets, but you can see that if you compare different triplets with each other, and you see this with the hazard ratios, it's very, very hard to compare one study exactly with another. And so I would just emphasize that if you're looking at a triplet versus a doublet, you have to compare the randomized studies as actually Jesus did, looking at age and risk in that exact comparison. At this meeting, I want to emphasize a couple of studies to highlight what was actually the major choice for this first case was the daratumumab POM-DEX. The French group will be presenting some follow-up data on the DARA POM-DEX, abstract 1824. So just draw your attention to that, which is showing an excellent response rate with this particular combination. I would also mention that we have quite a nice abstract also from the French group. This is in patients who are relapsing off the IFM 2009 trial, so the VRD plus or minus stem cell trial. This is a study looking at pomalidomide, cyclophosphamide, DEX. Rather an aggressive combination. It has the dexamethasone with the 4-day pulses, with a very high overall response rate. There were significant dose reductions mentioned in this abstract, I think related to the dose of the Cytoxan and the DEX, but I would encourage you to take a look at this abstract. And so if we move forward with a second case here, this is a younger patient with what seemed like early stage disease. Fish testing, unfortunately, was not done initially for this patient. Related to age, the patient was treated with VRD, autologous stem cell transplant, no consolidation, and then len maintenance, achieved a CR. The patient relapsed after 18 months and was retreated with KRD. A shorter remission. This was just right around the time when the DARA POM-DEX regimen was approved, and the patient was then treated with DARA POM-DEX. And unfortunately, this worked, but there was a relapse after that. And at this point, the bone marrow showed that there was an 11-14 translocation, also with an additional 1Q plus abnormality. And so this is a patient who has been exposed to quite a variety of drugs. And so as I ask this next question, I would like you to consider it in a way in which you would say, if you had access to these options that I'm going to put in front of you, what might you choose as your best choice? And so let's vote. And so the options that I'm offering to you here are to reinduce with a salvage transplant, or to consider a number of these experimental agents that are available within trials. Venetoclax, selinexor, ixazomib, CAR T cells, which obviously be a topic of discussion here at ASH, the anti-BCMA antibody approach, or some other experimental approach that happens to be available to you locally. So if you could vote on this, that would be great. We'll see. Okay, so it seems that most of you paid attention to the 11-14 and selected number 2 with venetoclax, with the backup choice of number 5, which is the CAR T cell approach. So this is quite interesting, venetoclax or CAR T cells. Very, very good points for discussion. So let me go ahead and just briefly make some comments about some of those therapies, particularly where there will be some updates at ASH this year. Obviously, we have all these different classes of agents, the monoclonal antibodies, the immune therapies, the proteasome inhibitors, also the cytotoxic, the HiDAC, BCL2 with the venetoclax, and then the newer agents focusing on selinexor and the CAR T cells. So we have these range of classes of agents that we can consider right now. To talk about the venetoclax, which was selected as an option for this particular patient, there are a number of possible targets in this BCL2 pathway. There's also MCL1 you can see is in this pathway. Venetoclax is focused on the BCL2 part of this pathway. The data from venetoclax was presented last year at ASH. I would draw your attention to the fact that it's very, very nice that the single agent and the combination therapy were just published in Blood right before we headed out to ASH. I don't know if any of you had a chance to see these data, but it's very nice that we now have the full data on the venetoclax data published. The key part is in the middle part of this slide right here, showing that there was an overall response rate of 40% in the translocation 11-14, with a significant depth of response you can see here. So very, very nice to see that. If we go forward to the combination using Velcade Dex, really quite impressive. That if you look over to the right, an overall response rate very high in patients who are have had 1 to 3 prior therapies and are not resistant to Velcade. Obviously, a big difference if you are resistant to Velcade or not, but even here you can see some efficacy, and so it's very interesting to see how the further development of venetoclax will play out with these data. The other agent which is presented in several abstracts at ASH this year is selinexor, which is the selective inhibitor of the nuclear pore. A lot of interest in how well patients are responding with that. The primary trial is the selinexor plus Dex. And in this particular trial setting, you can see here that there's been a focus on looking at an unmet need. And so you can see here a focus on an overall response rate, which you can see across the top, but looking at patients who are quad or even penta-refractory, so trying to identify, and you can see it is happening. There is a response rate, including VGPRs, in patients who are substantially drug exposed and resistant. And also, because of the mechanism of action related to the oncogenes, one would actually anticipate maybe there would be benefit in patients with a cytogenetic high risk, and it is interesting that there is an efficacy in patients who do have high-risk disease. Interesting right here with deletion 17p, so something to be aware of. If we move forward, what about the other? It's like the other child, the anti-CD38 monoclonal antibody isatuximab. And these are the data that were presented by Joe McHale at ASCO. And so there is substantial efficacy with the other monoclonal antibody. And so there are combination trials, and there will be data presented at ASH looking at isatuximab, and we have to see how the development proceeds with the other anti-CD38 monoclonal antibody. Quite important depth of response, which is maybe not quite so clearly dose-related with this antibody. And then, obviously, with significantly prolonged remissions with this antibody. Another agent which is not used a lot but is available for treatment, bendamustine, about a 68, a significant response rate with the bendamustine POM-DEX combination, and so it's something to be considered if you happen to have that available for use. But I think that one of the main topics that we'll all be hearing about and talking about at ASH this year is what about the CAR T cells? The first point to emphasize is that certainly not trivial to collect the T cells and to have the lentivirus available, and then to do the engineering, and then obviously to infuse. So a significant, rather cumbersome, and as we're learning, potentially quite expensive approach. A key point which relates to both the efficacy and toxicity is that all of the CAR T cells are not the same, and there are different parts to the internal chain here that influence both the amount and the speed of the impact of the CAR T effect. And so I think that when we're thinking about the efficacy and toxicity of the multiple small trials that we have information from at this point, this is an aspect to consider, that these CAR Ts are not all the same. And so you're probably familiar that there have been a number that have been presented from the different groups. A key point here is you have here 12 patients, 18 patients, 6 patients, 19 patients. And so we're faced with what looks like some pretty good responses, but all small experiences with different levels of toxicity. As you know, there was quite a bit of excitement at ASCO with the data coming from China with what appeared to be rather good responses, and also very, very acceptable toxicity. And so how that proceeds is an area of a lot of interest. This is just to give you an example. Obviously, you can see dramatic benefit in a scan, but this is the problem, that you can have these huge cytokine release problems, which are quite variable from patient to patient. Here a lot, and here not so much. Here you have a response, and then this pattern of cytokine release. So this balance between efficacy and toxicity, clearly an important aspect. So at this meeting, one of the main abstracts that will be presented as an oral is abstract number 740, the anti-BCMA CAR T cell. In this case, it's 18 patients. There was a dose effect, which they comment on the abstract. If you look at patients who receive more than the 50 times 10 to the 6 CAR T cells, a high response rate, VGPR 8 out of 12. Again, we're still looking at these small numbers. A lot of CRS, but mostly tolerable, only 2 grade 3 being reported, and so they're indicating promising efficacy and, in this case, manageable toxicity. So be very interesting to see the details of that. Immediately after that, there will be a follow-up. At last ASH, there was the phase 1, part 1 of the anti-BCMA monoclonal antibody against BCMA with a drug conjugate, and the preliminary data were presented at the last ASH. At this ASH, the immediate following abstract, abstract number 741, will give the phase 1 part 2 results. In this case, you can see there were 35 patients treated. Again, there's some quite important deep response, stringent CRs, VGPRs, a 51% greater than VGPR with this. Overall response rate around 60%. And so a PFS of around 8 months. And so this is quite interesting to see what can be achieved with an anti-BCMA monoclonal antibody versus the straight CAR T effect. So encouraging results. So interesting to see the details of that. So there are a range of new agents. There are the monoclonal antibodies, including the one that I've just mentioned. We have our immune modulating agents, the inhibitors, cytotoxic agents, and these other agents. So very, very interesting to see which ones will be moving forward most strongly. My final thoughts, just for discussion, is that among the approved drugs, we actually do have some amazing choices now, especially early in the disease with the DARA and other combinations. However, despite that, the truly refractory patients are still coming into our office, and we need to select between these various trials and try to do our best to guide patients through these different, exciting, but sometimes very, very different trial options. And so with that, I'd like to stop. Thank you for your attention. And we have time to go through and see what did the panel think about these choices that I offered. Okay, so for this first patient who was refractory to Len and Velcade, I had offered some choices, and it seems that actually we mostly chose Darapom-Dex, as did many of you. Vincent selected carfilzomib Lendex. So maybe you want to comment on that?
Oh, I mean, in the absence of randomized trial, it's very hard to know what the best choice would be for a patient who's Len and bortezomib refractory. You have many choices. I just chose to be contrarian only to highlight 2 points. One is that there are a substantial amount of data that show that carfilzomib can work really well even in patients who are refractory to bortezomib. So your patient was progressing on bortezomib, that doesn't mean carfilzomib won't work, and so that's important to highlight.
Definitely true.
And the second point is that lenalidomide, when patients relapse on lenalidomide maintenance, they're often taking very small doses, and therefore it doesn't really automatically mean they're len refractory. They're refractory at that dose, but they could still respond at the full dose, particularly in combination. And so I just wanted to highlight that I think DPD is a very good choice as well.
Right. No, I think that both of those points are important, especially related to drug access.
Yes.
If you happen to have access to lenalidomide and maybe not to pomalidomide, I think that this is a key point. And if you have access to carfilzomib and maybe not DARA, these are 2 very important points. Okay, so the second point, obviously, which of the new agents would our esteemed panel select here? And what came out of that? Well, actually, for this patient related to the 1114 and the data indicating the BCL2 correlation with the 1114, we did, in fact, select the venetoclax. And so maybe I can ask the panel, beyond that, what the audience picked as their next best choice was CAR T cells. And so maybe we can go down, and would the panel agree with that as their next best choice among the different options? Philippe.
I would like to speak about venetoclax, in fact, because you have proposed many new agents or immunotherapies that are not targeted treatments, in fact. And with venetoclax, maybe for the first time, especially in the era of personalized medicine, etc., we have a drug here that is mostly effective in translocation 1114. So I think that maybe this is the first targeted agent that will be available for myeloma. So this is something to be highlighted, to my opinion.
Yeah, absolutely, yes. So obviously, in this case, there was that correlation where we do have that precise idea to use a drug that's targeted. But beyond that, maybe I can ask the question a little bit differently. How do you look at, I showed you the two abstracts that we will see this year at ASH. We have the CAR T, and then we have the monoclonal antibody against BCMA drug conjugate. Would anyone like to comment on their view of those two approaches? Jesus?
Yeah. I think the BCMA conjugated as well as the bispecific BCMA are really very promising and will be relatively easy to use. The CAR T cell is much more complex to use, but from a point of view, the CAR T cell are going to replace the allogeneic transplant. It's going to be, from my view, the future of the allo transplant. It's clearly different from allo, but it's also based on immunotherapy and trying to exploit the immune response in these patients with allogeneic cells.
Any other comments? No?
I would like to agree. I mean, we have done the CAR T trials at Mayo with the BB2121 for myeloma. That's being presented at this ASH meeting. It's quite well tolerated. Almost all patients have responded. There are 7 or 8 different CAR Ts against BCMA that are being tested. This is the future. If it is available to you on a clinical trial, certainly that's something to consider, but it's very hard to get on these clinical trials.
Right.
And patients will have to wait a week or 2 for the cells to be collected and reinfused. So it's not that easy to get it. But it is certainly very promising. And if and when they become commercial, it will be a valuable addition for the treatment of myeloma.
Definitely.
Okay. All right. So let's bring it back. We have time. We will ask you one more time about your choice for these 2 cases. In this Len and Velcade refractory patient, maybe just tell us one more time what you would pick. If we can get this to go forward. Let's vote again. There you go. All right, so what would you pick for this patient? If you wouldn't mind voting one more time. If you would, many picked the Darapalm Dex or yes, so see what you think this time. So, as usual, today the Dara has increased its lead, otherwise relatively similar. Okay, so the final point is just to see what you think about some of the new therapies. This is the same case, and then we had the options which included, if we can go forward again, the venetoclax, a targeted therapy, or the CAR T cell, or maybe one of the other options. So if you could vote again, assuming that you would have access to these options. Okay. well, venetoclax really did win out. And some improvement in the CAR T cells. So those were the two. But actually increase in also the anti-BCMA. Interesting, but emphasizing the choices that were made initially. Okay, well, this is really good. What we need to do now is to try to close up with some overall recommendations. And this is something that turned out to be quite popular last year. And so what I'd like to do in closing is just to have Vincent come up and take us through the treatment algorithms and with some discussion points. So please welcome Vincent one more time.
Yeah, thanks.
Well, we were just amazed at how so many of you can sit and listen to multiple myeloma for 3 hours. Either it's really interesting or you're trapped and you just don't know how to exit. And there's so many different regimens out there, so we thought we'll simplify it. We all recognize that people are from various countries where access is is a big issue, cost is a big issue. So some of it, if it's unrealistic, pardon me, but hopefully everyone will be able to use some version of this as the drugs get approved. So the first question was smoldering multiple myeloma, and this is just basically a summary, and I think most of us agreed that if a patient is potentially a patient with new myeloma or smoldering myeloma, you would look for myeloma-defining events. If they have myeloma-defining events, it's pretty clear we'll treat as myeloma. If they don't have myeloma-defining events, we are considering them as patients with smoldering myeloma. Now, Dr. Paiva just clearly said that there are some smoldering myeloma patients who are high risk. These are patients with IgA, very high monoclonal proteins, abnormal immunophenotype, abnormal cytogenetics like 414, del17, circulating plasma cells, and so on. And then they have a risk of progression of 25% per year, which is median time 2 years. And then all the rest have low risk. All of us agree that the low-risk smoldering myeloma patients should be watched. All of us agreed that the high-risk myeloma patients should be either watched or placed on clinical trials. This is where we left it. And then there was this brilliant question about, do we really feel comfortable that, what about the high-risk smoldering myeloma patients? Will we ever treat some of them on a clinical trial? And we marked that if the patients got evolving features or multiple high-risk factors, I put it as a gray area because it's gray. You're going to find some experts agree on this, some experts disagree. I take it patient by patient. There are some patients who make me very uncomfortable if they have a very high IgA and they've got deletion 17p and they're smoldering. I try to look for myeloma, and if I don't find it, then you watch them, and if the M spike changes, you just initiate therapy. That is a gray area, but I've marked that down as consider treating as myeloma. I'm more comfortable with that mainly because of the results of the PITEMA trial showing RD as improving overall survival. And then we moved into newly diagnosed myeloma, and then I think most of us agreed if we had access to VRD, that would be the default frontline regimen, except for frail patients who have multiple comorbidities in which you could do Lendex or even ixazimib Lendex. Now, Dr. Moreau forgot that my job was to talk about induction, and he asked me why I didn't cover transplant. Well, that was his job. But since now I'm at the algorithms, I can at least say that if the patient is a transplant candidate, Dr. Moreau, yes, you should do transplant. And that is the blue box. You do induction with VRD, and then you do an autologous transplant, and then the maintenance really depends on whether they have got high risk or standard risk. If they've got high risk features, most of us use a bortezomib-based regimen. That's about 20% of patients. All the rest, we use lenalidomide-based maintenance. The gray box is that not everybody wants to do an early transplant. Some patients really want to carry on with their life and delay the transplant till later. You saw in the IFM trial, the overall survival at 4 years is 84%, whether the patient chose the transplant arm or the non-transplant arm. So I'm very comfortable in selected patients for delaying the transplant, if that's really their preference. At first relapse, it's really more difficult because it's really limited by access. For example, in Europe, where many of these trials were done, not all of these regimens are available. Daratumumab is available only as a single agent. So this may be unrealistic for some people, but our practice is if the patient is not refractory to lenalidomide, daratumumab Lendex has the best hazard ratio, and so that's the preference. But any of the others in the gray box, which were all tested in phase 3 trials, KRD, carfilzomib Lendex, ixazomib Lendex, Elo Lendex, they're all good. This is not a multiple choice where one person is right. You know, it's just more important to make sure that if you try one and the patient fails, you try the next, and so on. This is a disease of multiple relapses and remissions, and use each available option. If the patient's refractory to lenalidomide, we have 2 approved regimens in the US. One is daratumumab bortezomib dex, and the other is daratumumab pomalidomide dex. Both of them would be our first choice, again, because of the hazard ratio associated with dara-based regimens. But that doesn't mean you couldn't try one of the others, and any one of those is fine. One thing to highlight is Cyborg-D, cyclophosphamide bortezomib dex. If we really start using lenalidomide frontline, transplant, and then len maintenance, it's quite possible that many patients have never seen an alkylator, and alkylator still works, and so cyclophosphamide-based regimens should still be considered. That's all I have. Second relapse I showed last year. I didn't show this year because it's just completely gone out of control. It's multiple choices here, CAR-Ts, BCMAs, antibodies. Dr. San Miguel was mentioning bendamustine, IV melphalan. You were mentioning melphalan to me, Jesus, just a few minutes ago. So any of this can be considered, but I cannot give an algorithm for this because it's really out of control. You just have to consider each available option, cost, convenience, what the patient's relapse to, and then make the choice. Thank you. Happy to answer questions.
Thank you so much, Vincent. I think that this is an excellent way for us to end. I would invite our panel. You have any final words of wisdom from the panel here? Okay.
I like that Vincent has mentioned the alkylators are important. In fact, we are going to sell melphalan and cyclophosphamide in 5 years' time, and one of the best drugs to rescue late relapses in multiple myeloma.
All right. Well, thanks so much to our panel. We appreciate you sitting here all afternoon. We hope you enjoyed it. Thank you.